Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who's 10 years of age and they have to attend every 6 months or so to have their right ear cleaned of this occluding, soft, mushy earwax and dead skin keratin. Their left ear is always clear of wax, it's only this right ear. And I suspect there's two reasons why this patient's suffering from earwax impaction in their right ear and not their left. In comparison to their left ear, this right ear has got near the entrance a little trench, a little pothole if you like. So I suspect as the wax is trying to naturally migrate out of the ear, it's falling into this pothole, this trench that this patient's got at the beginning of the ear canal. It's almost like a step, it's a step down. So as wax is migrating sideways, it falls down that step and then it's difficult for it to come back out. And I also say it's the consistency of this. It's quite sticky and mushy, so as it's migrating out of the ear, it's just attaching itself and adhering itself to the canal wall. Now, the wax plug extends right from the entrance to their eardrum. So quite often, some of the comments that I do see is they make reference to the point that I'm quite close to the wax, and sometimes some people are, they say I'm too close. Unfortunately, there's not much I can do about that, because if the wax isn't near the entrance of the ear canal and I'm having to insert the endoscope in the ear to see the ear, well, the wax is going to be quite close up. And especially cases like this where I'm having to stretch the ear canal open. So I'm actually using the endoscope to stretch the ear open because the ear canal entrance is very narrow. And the only way I can do that is to put the endoscope in the ear. And obviously I need to put the endoscope in the ear anyway to remove the wax. So I can't really help the location of the wax. If the wax is near the entrance, then of course it's going to be near the entrance. It's going to be close up to the tip of the endoscope. And as we start clearing the wax away from the entrance, then you'll see the wax is further away. So I'm just trying to lift this wax plug off the bottom of the ear canal. Now, what I do is whenever I perform a procedure, when I document the patient's procedure and treatments that we provided, I log little tips for myself in future. So if the patient returns and needs the wax removed again, I always make little notes for myself to help me the next time. And in this case, I've left a note over the years after treating this patient's ear that the key to this is trying to remove this from the bottom of the ear canal. That's the key territory. If I detach this from the base of the ear canal, it just then makes the whole procedure far simpler. And as you can see, I'm just targeting the bottom of this ear canal. I'm trying to separate it. Other notes I sometimes make for other patients, for example, if they've got a really hairy ear and it sometimes can obscure the view, so I document that. Patients with very hairy ears, I try to avoid or minimise the use of any olive oil drops, if at all possible, sodium bicarbonate drops, whichever drops I'm using. And that's because these drops, as you instill it into the ear, they do coat the hair strands, and then when you insert the endoscope into the ear, inevitably they're going to be in close proximity to these hair strands as you're inserting it, and if a particular hair strand is greasy and oily, it can just smear the lens of the tip of the endoscope. So it's just another possible note. Or if they've got a specific abnormality or landmark in the ear, for example, if they've got an osteoma, which is a bony spur, or exostosis, also known as swimmer's ear, where there can be 3 protrusions of the bone deep in the ear, or if there's a crater in the ear canal. I just leave little pointers for myself. So as you can see, I've separated this from the floor of the ear canal. Now, unusually, the wax plug is still not coming out, and typically with this patient, once I've removed it from the bottom of the ear canal, the wax plug is removed quite easily. It comes out without any force or any resistance. So I'm thinking to myself, why isn't this the case here? So I've just put some olive oil spray in there, and you can see that blurring that I'm referring to. Now in part it's also blurring because the oil's in the ear still as I'm suctioning, so the suction probe is also suctioning the oil, and as it's suctioning the oil, you can get a bit of blurring. And slowly now it is working out. And the reason why this wax plug put up a little fight is because once I remove this, you'll see that there is some plugs of wax on the eardrum, and I suspect they were attached to this main plug. And as I removed the main plug, those three remaining plugs separated and stayed connected to the eardrum. You'll see a couple of those were really strongly attached to the eardrum, and it was quite but to be very forceful in the sense where we had to manipulate that off the eardrum to release it. Now you can see the skin adhesions at the bottom. It's the white silvery matrix that's enveloped this wax plug. So that skin was once upon a time lining the skin of the ear canal itself, and that skin dies and it separates and it should shed out of the ear naturally. But here it's adhered itself and enveloped itself around the wax plug. So I've just brought this to the entrance now, and if you remember at the beginning of the procedure, I mentioned this patient's entrance is quite narrow and twisty. So as I'm bringing it through, it's got trapped. Now, because this is now at the entrance, the endoscope, I'm not positioning it in the ear now, I'm holding it in suspension, so it's in mid-air. We're not resting. I'm using the tragus, which is the cartilage just at the entrance of the ear on the outside part, just gently to rest it on that. But more or less, I'm holding this in mid-air and angling it towards the entrance, so I can then view myself removing the plug out of the ear. So I'm going to re-enter the ear. You can see there's still a bit of wax that's separated from that main piece that I just extracted. So we're going to just peel this away. And we're going to bring it out of the ear. And once I have, you're going to see those hardened wax plug that are stuck on the eardrum. So I'm going to stretch the ear again. There's some dead skin wax on the posterior canal wall. So at this stage, the patient can hear significantly better because the occlusion is removed. So there's some skin there, which I'll remove a bit later. So you can see those almost pellets of wax and coating. They're very dry. So the first one came away pretty easily. And then there's one or two even in the anterior recess. So the anterior recess is the region to the right-hand side. This is the patient's right ear. So the anterior recess is on the right-hand side, and vice versa if it was the left ear. So the anterior recess is a little alcove, or recess, hence the name, created by the ear canal narrowing as it approaches the eardrum and widening back out. And you can see this is actually stuck on the drum, and I'm having to peel this away. You can see the eardrum slightly moving, and I've got to just be careful with that suction probe. It's in close proximity to the anterior canal wall, which is the bony part, and that is a very sensitive part of the ear. So I'm just going to go back and try to remove this other piece. You can just see how dark it is. It's only been 6 months since we removed this, so it has oxidized pretty quickly, this wax plug. And there's a couple there now in the inferior recess, and it's so difficult to view because as the ear canal approaches the eardrum, not only does it narrow in and widen back out, but it narrows upwards and then back down again, which creates a little trench, a little basin, a little inferior, so the bottom part inferior recess. So you can see I think for this bit I was actually stood up and looking down into the patient's ear as they were sat. So just some skin that I'm going to peel away there. So it's going to gently peel this away. See, it's very dry in there. And this is more near the entrance. This is more lateral. So just going to mop this up. Now, when we're on the lateral part of the ear canal, the cartilaginous portion, we can apply a bit of pressure against the canal wall because unlike the bony part of the ear canal, which is rigid, the cartilaginous portion is semi-flexible. It's got a thick layer of skin, which provides a bit of a buffer if we put a bit of pressure on the ear. And this is one of the advantages of the endoscope. We've got such a wide field of view that I'm able to see regions of the ear like this that I typically wouldn't with a microscope or an otoscope. And once more, it's quite close up because at this bit it's right near the entrance, so I have to put the endoscope in the ear, otherwise I wouldn't be able to see inside the ear. And by virtue, if any wax is near the entrance, it's going to be close up. So just mopping this back portion away. And they've also, this is that part of the ear, as I said, there's a little step down, and you can see I'm working in that little trench that they've got near the entrance. We'll just remove some dead skin debris from there. I think there's a little bit more in there actually in a moment, so I'm going to go back in. So you can see I'm looking down, and again I'm stood up looking down here. So I want to make sure I've got the right angle. I'm just trying to get some of this wax and skin away. Now the patient's doing everything right. They don't poke in their ears, they don't get water in their ears. We're hoping as they get older that maybe that step that I made reference to levels out. And maybe the consistency of the wax just differs a bit, so it's not as sticky and glutinous, so it doesn't attach itself to the canal wall. But the patient doesn't mind having their ears cleaned, and the patient, bless them, the patient's mother was always asking the patient if they can hear, because sometimes it's the friends and family who notice first when someone can't hear, because the person themselves, it's a gradual deterioration as the wax builds up. The hearing gradually deteriorates, so they're sometimes oblivious to it, and it's the patient's mum is always asking the patient, are your ears okay? And when it comes to 6 months, the patient's mother kind of knows it is time, even if the patient's not complaining, let's go and get your ears cleaned, because we don't want to leave it too long, because if you leave it too long, the infection can get worse and can get painful, and it can be much more harder to remove. So I'm just mopping up some of this staining, this stickiness that's on the surface near the entrance. As we remove the wax plug, it makes contact with the rest of the ear canal, and it can cause a bit of staining. So we're going to now go back in, view the eardrum. There's some vascularization there, you can see on the hammer bone, the blood vessels are dilated, but it's just because the wax was impacted against it. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.